Good evening and happy Teach Me Tuesday. My name's Lisa Houston and I think my voice is back. This is an exciting development after 2 weeks of being sick, but here we are. Today we are talking about common medications used in the NICU. In our unit, we are doing check-ins with our nurse residents throughout their time with their preceptors and at the bedside in their 16 weeks of residency. And my favorite question to ask is why? Why is your baby on this medication? Sometimes I think even with simple medications, we kind of tell ourselves, oh, I know why they're on that, or of course they're on vitamins. All babies are on vitamins, but why? Why are we on vitamins? What are we trying to help the baby get that they would be otherwise missing if we weren't replacing it? So today we're just going to dive into 7 medications. Next week we're actually going to do 7 more that are a little more obscure, maybe not used as regularly as these 7, but let's dig in. So when we're talking about medications in the NICU, we have to remind ourselves that many parts of our babies are premature. So that includes our kidneys and our liver, where a lot of medications are processed. So we can't just think of medications and think, oh, if we give this to an adult, we can give this to a baby, or, oh, of course you can use those 2 medications together, or, oh, they'll be fine without those vitamins for a couple of days. Because our babies are so vulnerable to the lack of medications and to potential negative side effects, we have to be very cautious of what we're giving them and how much we're giving them. It's also crazy because I will be teaching and, a lot of our nurse residents are just out of nursing school, and I'll be like, when we give it mgs per kg or something, and like in adults, and I'm like, oh wait, in adults they don't sit there and calculate that, and they're just going to give everybody a pill or a similar dosing of something, a bag of antibiotics. But in the NICU, because our babies are so little, we are giving so many of these medications per kilo, and if you weigh less than a kilo, you can imagine how small some of these volumes are. So being aware of what our standard dosing is and what common interactions are will help us be successful with our medication administration. So let's get started with what I've decided is probably our most commonly prescribed medication in the NICU, caffeine citrate. So you think of caffeine, you tell your parents the baby's on caffeine, you give the baby caffeine, you think you know what caffeine's about. We give caffeine, right, to help apnea of prematurity. So caffeine must be a respiratory medication. When really, in all honesty, caffeine is a neurological medication. It's a neurological stimulant that affects the respiratory centers of their brain. It helps reduce the risk of apnea and helps maintain better breathing patterns. One of the interesting things about caffeine that I always like to talk about is when I started my career, which is coming up on 20 years ago, we didn't give caffeine until the baby was ready for extubation. We weren't necessarily giving caffeine to every single baby that came into the NICU. We would often plan our extubations and we would load them up the night before with their loading dose of caffeine and then give them their maintenance doses. But now we're giving caffeine on mission. Part of that is because they saw neuroprotective benefits to babies who are on caffeine from an early age. Plus, we are also then giving them the opportunity to get this therapeutic level built up in their body prior to extubation. Also, we extubate babies a lot earlier now than we did 20 years ago. So some of our babies are only intubated for a day or 2 at most. Some of them never. We have a couple 24-weekers in our unit right now that weren't intubated. One of them is now at 7 days, but we are keeping them extubated for longer. So getting that caffeine on early allows that therapeutic level to get to a good place. When we're talking to parents about caffeine, right? Because remember, you can't go in the room and say to the baby, it's time for your caffeine. Do you remember why you're getting caffeine? But we can't ask the parents. And we need to remind them that just like we have our cup of coffee to wake us up in the morning, we're giving babies caffeine to work on their brain. Some of these neurological pathways that connect the neurons in your brain to your diaphragm via your central nervous system aren't developed yet because they're not supposed to be. Our babies are born premature. So this expected outcome of apnea of prematurity is treated with caffeine, and it helps us maintain good breathing patterns for our babies while they're in the NICU. Next most common are those AMP and GENT, right? You hear your baby's getting a rule out for sepsis, whether at birth or immediately after birth or in the first few weeks of life. And AMP and GEN are some of our broad spectrum antibiotics that we use to cover both gram-positive and gram-negative organisms. Some things we are covering include group B strep, E. coli, Listeria, Pseudomonas, those big ones that we see in the NICU. It's important to have antibiotic stewardship to make sure that we aren't overusing antibiotics. There are great calculators out there, sepsis risk calculators, that we can look at how long was mom ruptured, what was the color of the fluid, did the mom have a fever during her labor and delivery process. This helps us determine if AMP and GEN and starting antibiotics is our best process. After that, we have got our old friend surfactant. So surfactant replacement therapy is given to premature babies to help improve lung function, right? It's administered right in that ET tube. Maybe your unit is doing the Lisa method, affectionately named after me, I like to tell people, but that less invasive surfactant administration, where maybe you're giving surfactant through a small tube similar to an LMA or a feeding tube or an umbilical catheter. You can leave the baby on like a Fisher-Paykel or an NIMV setup while giving them the surfactant. But it goes directly into the respiratory system. Surfactant's absorbed by the alveoli, and it allows the alveoli to become more lubricated to reduce surface tension and maximize gas exchange. And anytime we have a lack of surfactant, it really affects their ventilation, which in turn is going to affect their oxygenation. So giving surfactant, having surfactant administration guidelines to kind of guide the practice is helpful within any unit. There's also usually protocols about how long after you should wait to suction if you can. Some units kind of turn the baby during surfactant administration, some do not, but you're bagging it in via BPV on your ET tube or via bag mask if you're doing the Lisa method. All of our babies that are born prior to 34 weeks really are missing this big push of vitamins that babies get at the end of their third trimester. They're getting a push of vitamin D, calcium, phosphorus for bone mineralization. And when babies are born too early, they miss that major push of vitamins that happens during the third trimester. Because of that, we do have to give them vitamin supplementation. Additionally, breast milk alone doesn't provide all of the multivitamin levels that our babies need that are born early. That also goes into the fact that they have higher nutrient requirements because of their prematurity and the calories that they are burning. So we give the babies multivitamins and vitamin D to help come up, make the difference of some of these. If a baby is on pure formula and high calorie formulas, they may not need the vitamin supplementation due to the vitamins being in the formulas. Those would be those babies that don't have breast milk or are not units that don't have donor milk, or the baby has completed their donor milk time period. When you work in a unit that serves the micropreemie population and respiratory distress syndrome and TTN and all of that are some of your earliest diagnoses, diuretics are going to be something you see commonly. So furosemide or Lasix tends to be one of our most common diuretics that is used along with chlorothiazide. This helps deal with that extra fluid buildup that can come from the heart-lung cycle and some of those immaturities and damage that can actually happen to the lungs from barotrauma, from mechanical ventilation. So anybody with pulmonary issues or our kids with those cardiac defects are going to need diuretics to help keep that extra fluid off the lungs. During that time, we have to be very mindful of their electrolytes and their bone density labs, because diuretics leach calcium out of the bones when you have babies that are already not getting enough calcium and phosphorus. And then we put them on diuretics, it's taking it out of the bones. They cannot lay that bone structure down. So we have to be super mindful that we are giving them all of the support they need with their calcium and phosphorus via their enteral feedings and their supplementation while on diuretics. We do see a lot of vasoactive medications, like our blood pressure medications. Specifically, the ones we see the most are going to be our dopamine, our dobutamine, and our epinephrine. These are primarily given for hemodynamic instability, so our babies with low symptomatic blood pressures. So babies that have low urine output, poor capillary refill, cool skin, in addition to their low blood pressure, may need some vasoactive medications. Dopamine and its similar inotropes have vasopressor and inotropic effects. Dopamine will cause peripheral vasoconstriction, so that it's causing some of that blood flow to get closer to the heart, as well as increase the strength and force of the heart contractions. So when we think about cardiac output, which is our heart rate times our stroke volume, we want to do our best to affect both sides of that by getting more blood to the heart, so that on each pump of that left ventricle, we are sending more blood out and really saying, how can we make that left ventricle more effective? And we can do that by working on the strength and force of those heart contractions. So primarily, prior to having an echo, dopamine will be our first line of defense. We may end up with dobutamine if our echo shows us that we have poor contractility, or if we really need to work on our left ventricle. Epinephrine also will help with our left ventricle function. So if you've had an echo that says like, hey, the blood pressure is poor because that left ventricle can't do its job and push the blood out, then that's going to end up being where we get some of our force, is in that epinephrine. Finally, fluconazole. If you are a unit that admits extremely premature babies, especially those born before 28 weeks gestation, maybe even down to 26 weeks gestation, you too may be using fluconazole or Flagyl for prophylactic treatment of fungal infections. Those babies that are born extremely low birth weight and extremely prematurely born prior to 26 weeks have a limited skin barrier function. So they are very high risk for these fungal infections. We do lots of things by keeping them in humidity, doing good skincare practices, but sometimes it's not enough. So having some sort of fluconazole treatment plan, prophylactic treatment plan, we give our babies 2 doses, 72 hours apart, to help with our preventative measures for babies at risk for fungal infections. There's the word. So in review of these 7 medications, we always need to make sure that anytime we're giving a medication, we've looked it up. We've looked up any compatibilities if we are giving our medications IV, even caffeine, double checking its incompatibilities. It's a medication we give so routinely, our AMP and Gent we give so routinely, but have we gone back to make sure it's compatible with the fluids that we're running? Making sure it's the correct medication, correct route, that we're giving the correct dose, doing med calculations to make sure that those tiny doses, both in milligrams and milliliters, are the safe doses for our babies. Making sure that we understand our mechanisms of action. My husband often says this phrase of, if you can't explain it, you don't understand it. And it's very true. Being able to explain to our families why their baby is on a medication tells them that we understand. Not only do we know what this medication does, but we know why your baby is getting it. And they should too. Our parents should be considered the primary caregiver of this baby. They are part of the care team. They need to know why their baby is on each individual medication. It's our job as bedside nurses to make sure that we are educated so that we can then explain it to them. Thank you for joining me on this Teach Me Tuesday. I look forward to seeing you next week, where we're going to talk about 7 more medications. If there's any medications you would like to dig into deeper, please comment below, and we will look into those for you. Have a great night.